Hello everyone, welcome to the 12th Annual Pre-Health Conference. I would like to welcome Dr. Hiserote.
All right, good morning. Thank you for coming. So we're going to talk a little bit about osteopathic medicine this morning. So I'm hoping that I can answer some of your questions about it, give you some thoughts about, what my perspective is on osteopathic medicine, and where is it going, and how does it fit within the medical model today. That's kind of the goal of the morning, all right? And so please feel free to answer or ask any questions you have, and hopefully I can answer them. So as we're going to move on here a little bit, you always have to start with the history. And the history begins with this gentleman. This was Andrew Taylor Still. And so this is very interesting because this is about 140 years ago, okay? And this guy was an MD Civil War surgeon. He was active with the anti-slavery movement. He was very much active at the Kansas-Missouri issue that was going on around the Civil War. It was a very trying time. And he was trained in the usual fashion of MDs in that it was an internship. Basically, you hung out with a doctor for a while who had gone and hung out with a doctor for a while, and then maybe you would go take some classes. At that time, one of the prominent schools was Rush, still there, right? And you would become a physician. And most of the way that healing occurred was through the administrations of medicines. Most of that was usually alcohol, opiates, a few other things, some tinctures of this or that. Most of the time it made your patients pretty sick, and that was the process, was they thought you'd throw it up and then it would leave your body kind of thing. It was very common. And he became a little disenchanted in that medical model because he lost 3 of his children to spinal meningitis and 1 of his wives. And that has a way of changing a man's motivations. And he was also raised by the Shawnee. He was raised near a Shawnee reservation, and he spent a lot of time with them. And so he had a little broader spiritual picture than, say, the Methodist conservative religion that was very prominent in that area at that time. And so it caused him to think a little bit more. And he basically decided that there's got to be a better way. And what he did is he came upon the thought that an osteopathy, or osteopathic medicine, as he would call it, is going to represent the ability to encourage your patient's own inherent healing potential. So he said to you that you are perfect in your health, and that you are always striving towards health, and that disease is actually an absence of health. And that if there was an alteration in the body itself, that it would alter the function, and the function is how we fight disease. And so he spent many, many years studying anatomy and physiology, and he learned to use his hands in what we would call manipulation. And he went out and he treated many patients and became quite famous because he would take patients that others would usually walk away from, or these people would die, and a lot of them survived because he was thinking about how can I facilitate your health or the health of the patient to take over. And that was a main principle about what osteopathy is still about today. Okay, this is how we look at it, which is a deviation a little bit from what typical medical model teaches us. So the first school was in 1892 in Kirksville, Missouri, of all places. And the only reason why it ended up there was that he was run out of most of the towns in Kansas and Missouri because he was having these radical ideas that he was treating his patients without medicine. And in fact, some of the conservative religious groups at that time thought that he was possessed by the devil because he was healing with his hands. And so it was kind of a rough time. And when he made it to Kirksville, Missouri, of all places, they decided that he wasn't so bad. And so he made him home there, and that's where the first school. And in fact, that little house is in a museum in Kirksville, Missouri, inside a huge library that's dedicated to his stuff. This is the first class. And the interesting thing about this is that it matriculated 17 men and 5 women. This is in 1893. 5 women. That is hugely progressive for that time. Tremendously so. And most of that came because he had a very strong mother who ran the farm and the ranch, while his father was a circuit preacher. So he'd ride around, was not home very much. So he realized that women were very capable, and that pretty much influenced him for the rest of his life. So 5 women graduated in the first class. All right, and so there was research being done even back as far as 1898, studying around changes in the physiology based on the anatomy of the body. Okay? So when I say osteopathic physician, like for you, what does that mean to you? What do you think of that? If you were to ask me, what do you do, and I say I'm an osteopathic physician, what would you think about that?
That's studying the insides, like the inside anatomy.
Studying the inside anatomy. Okay, so that's an enlightened perspective, because usually that's not what most people say. So that's good. What would you say?
I would think that you're a doctor.
Okay, I can get away with that. All right, but there are lots of different kinds of doctors, right? So what else would you think?
That you focus on the well-being of people, try to maintain it.
So I've already biased this crowd way too much. Okay. The usual answer is oh, you work with bones, right? Osteo, bones. That's the usual thing that you get to, right? And in Still's mind, osteopathy is about the foundation, about the infrastructure that supports it all. And so osteopathic or osteopathy does refer to bone in many cases, but it goes a little bit further back. It goes into the foundation aspects of it, all right? So anyway, if you think about the development of osteopathic medicine, in 1917 there were 5,000 DOs in practice, which that's pretty good considering it hadn't been around that long, right? A couple other times that were important. In 1947, the first osteopathic hospital was approved for residency training. Now, for those of you who are not familiar with residency training, the usual pathway for a physician is that you apply after you have an undergraduate degree of some kind. Usually a bachelor's of science, can be a bachelor's of arts, can be a master's. If you want to go a little further, that's fine. But usually you have to have a 4-year degree. Then you apply to medical school. Medical school is 4 years, whether it's allopathic, which is what the MDs go through, or osteopathic, which is what the DOs go through, right? 4-year MD school or DO school. Then after your medical school training, you do a residency, and that first year of your residency is usually called an internship, all right? Now, residencies, it depends on what you want to train in. If you want to be specialized in, say, family practice, okay, your residency will probably be 3 years, maybe 4. If you wanted to be, say, a cardiovascular surgeon, you're going to be in residency probably 8 to 9 years, okay? It takes a little bit longer to go that route. But in this day and age, just about everybody goes through and does a residency. There was a time where you could just do an internship, a 1-year internship, and you could go out and hang your shingle. But the complexity of medicine and the politics and the billing and such, that really requires you to do a residency. So you all have to start thinking about your residencies. And I think there's some discussions here on campus today. I'll talk about residencies too. I hope so. Anyway, there was an osteopathic hospital that had its own residency. So we were kind of on a separate pathway moving through the medical community. Yes?
When you say residency for specialty, are you saying including fellowship with that? So the 8 to 9 years? Or are you saying residency plus fellowship?
Yes. So for the surgeon, yes. Yeah. Okay. So then, let's see, in 1950, it brought the profession legal equity of practice. So we are now considered physicians and surgeons. But not all states in the United States considered us physicians and surgeons. And it took us truly into 1976, the very last state to allow osteopathy to be considered physicians and surgeon was, of all places, Louisiana. Louisiana. Who knew that they would be the last holdout? But they were. Anyway, moving on here. Okay, so as of 2013, in California, there's like 6,700 DOs that are licensed to practice medicine, right? And there are 2 medical schools that train osteopathic physicians, right? That's the one in Vallejo here, just not too far away. And then there's another one down in Pomona in California, which was my alumni school. Sorry. And in 2013, nationwide, there are 70,000 licensed DOs with 29 DO accredited medical schools. Now, this has changed. As of, I think, within the last month or so, there are now 40 DO medical schools in the United States. So osteopathy is growing really fast. Osteopathic medicine is one of the largest growing medical training facilities in the United States. So let's see, what else? The thing about it is when you think about an osteopathic physician, you have to think in terms of, well, what does that mean that I can do if you're going to be an osteopathic physician? Well, we are fully licensed to practice medicine in all 50 states, and depending on your training, there is no specialty or subspecialty you cannot participate in. Okay? And in fact, coming up in the next year or two, there's going to be a lot of testing and administrative aspects that are going to merge between the allopathic profession and the osteopathic profession, and so we'll be even more closely aligned. But you know, if you wanted to be a surgeon, you want to be a vascular surgeon, if you want to be a family practice doc, if you want to be a peds doc, if you want to do OB, all of that is open to you if that's what you want to do. Okay? And we're licensed to use all forms of drugs and surgeries if that's what we want to do. And we're certified in all the commonly accepted subspecialties, like I said. All right? Except for there's one other subspecialty that we are specifically unique in, and that's osteopathy or neuromuscular medicine and osteopathic manipulative medicine. And that means we use our hands. All right? So we'll talk a little bit more about that. But the big question which most people ask is, what's the difference between a DO and an MD? If they have an undergraduate degree, they go to a 4-year medical school, they train the usual things like physiology and anatomy and pathophysiology and biochemistry and all those things, right? They do residencies. Oftentimes we're in the same residencies. We're working side by side in the same residencies across the United States, right? So what's the difference? Why would I consider becoming a DO? Why, more importantly, would, as a patient, want to come see a DO? That's probably the more important question. And this is the question that you have to ask yourself and ask, is this something that's synergistic to who you are and how you see your future in medicine and how you see you're going to interact with your patients, right? So, one of the differences that I like to point out is osteopathy offers a concise medical philosophy. So you don't usually talk about philosophy very much in medicine, but in fact, when you see patients, it's all about philosophy in some ways. The philosophy is the art part of medicine. It's the part that you decide that how you bring the science that you've learned and is constantly growing to bring to address your patient that's sitting in front of you with whatever issue that they have going on. Okay? And we kind of have a very concise philosophy that we put together, and it starts to become articulated from the day one. Yeah, I got one. Thank you, though, very much. All right, from day one. There was a UCSF medical student who was doing a project in integrated medicine. And so he found osteopathic medicine kind of fascinating. So he ended up shadowing us quite a bit. He'd come down and spend time in our classes and our labs and for several years, actually. And then one day he comes up to me and he goes, I got it. I figured it out. I know what the difference is. And I'm like, lay it on me. Let me know what you think this is about, because I always love to hear, you know, another person's perspective, especially in allopathic medical students' perspective. He says, you guys have these 4 principles that you lay on the students right from the very beginning, and you start hanging all the medical information and the clinical aspects around that. And it's a foundation that sort of stays in the concrete of how you think for the rest of your practice. And I'm like, you pass, honorary DO for you, right? But that's exactly kind of what it is. It's a way of thinking. It's a way of hanging the information that every doctor gets. And I would say it's only unique in osteopathic medicine because we have these 4 principles, but it's not unique in the fact it just means really being a good doctor. And there are lots of really good doctors out there, whether they be DO or MD. Okay? So what are those principles, right? Well, maybe I can get to it. All right. The other difference is that we have a very distinctive modality of diagnosis and treatment. Okay, and that modality is called osteopathic manipulative medicine. All right? Some schools will call it osteopathic principles in practice. You'll hear it in both ways. All right? And basically what that means is it's kind of physical diagnosis on steroids. All right? Very sensitive and integrative aspect of looking at your patient, and you use your hands. What you may not know is that your body kind of tells a lot more of what's going on inside by what's happening on the outside. And the study of manipulative medicine is the study of learning those interconnections. All right? Does that make sense, everybody? Sort of, kind of? All right, I'll give you an example in a minute here. All right. So let's get back to the principle part. What's the first principle? The principle is the body is completely united. The person is fully integrated being of body, mind, and spirit. And A.T. used to call it the triune of man. So mind, body, and spirit is highly overused these days. But we're talking about this actually literally in the sense of when you're dealing with the patient. So one part of this unity is that you are connected from the bottom of your feet to the top of your head. And whatever happens to you happens to the whole. Right? Now, whether or not you have symptoms from whatever happens really depends on what you bring to the table. So if you injure your foot, let's say you step on and cut your foot, right? You have a local injury of your foot. All right, well, fine, we're going to bandage it up. But now you can't bear weight quite on that foot the same way, so you start a limp going. And that limp begins to start changing the way that your pelvis bears the weight. All right? And maybe you had an old car accident at some point in time, and your low back kind of gives you a little trouble once in a while. And all of a sudden now your low back starts to give you a lot more trouble. Right? As you start having more pain. And with pain, now you have nerves that come from the lumbar region, lumbosacral region, actually the parasympathetics that come, and they actually dictate what happens in the lower end of your colon and some of your reproductive organs. And so now you're having problems with say, constipation. And better yet, your low back's hurting and you decide you're going to start taking some NSAIDs and maybe some opioids because you're having pain, and now your gut's really messed up. Right? So with this altered gait, and now you have your low back is beginning to hurt, so you don't move nearly as much. So now you're laying around a lot more. As you lay around, you start having pain in other areas. Maybe start having neck pain and headaches because we were built to move. Right? And this may affect your job, this may affect your life, may affect your children, may affect everything. So you are united within your own self, but also united with the circle around you, which is one of the things that we have to think about when we're physicians. Oftentimes when we treat a patient, we're not just treating the patient, we're treating the family, depending on where they come from. So remember that you're all connected. And then there's this mind, body, and spirit thing. And I'm going to talk about that when we get to the second principle about the importance. But your inherent health, the thing I started with a little earlier on, is that the fact that you within yourself has the inherent health that is always striving towards health. It's fighting disease, it's remodeling all the time. I mean, everybody in this room right now is infected. But there's probably only one or two of you that's feeling maybe a little sickly. But you're always infected. So, and part of us says, well, that doesn't sound very good. I want to be sterile. Well, actually, you don't want to be sterile. The fact that you're infected is this constant tuning up of your immune system. It's the part that really keeps you healthy. It's this inherent healing potential. It's this intelligence that's constantly working and remodeling your immune system. What do we do when we do vaccinations? Well, we just sort of kick the immune system in a certain direction so it's more likely to fight what we're trying to move against. So like right now, everybody's scampering for the Ebola virus, right? They're trying to figure out some vaccination for that. Right? We'll probably find one, all right? We'll see. But anyway, I'm going to talk about this just a little bit more when I get to the second one here. So the other principle is this inherent healing potential? And I used to draw a little circle or a triangle on a piece of paper for my patients. And I'd say, this is you, right? You have a mind. You have a body. And you have a spirit. And in this very stable triangular structure, you have this big H in the middle. And this is your health. We study the body quite a bit in medicine these days. This is the part we spend most of our time on. We move now towards working with the mind a little bit. The mental health is now something we're beginning to recognize has a huge effect on the overall health of your patients. So these two begin to talk to each other, back and forth. Okay? But this part here, we don't think too much about this. Occasionally we do. That there is a spirit aspect. And when I say spirit, I'm not talking about religion. When I say spirit, I say your ability to connect to something greater than yourself. If that means go climbing on top of a mountain, go for it. If that means you need to go to church and feel it there, fine. It doesn't really matter where you get it, but you have to have it. If you don't believe it, in your clinical training, you're going to be training at some of these places where they drag these people out from underneath bridges. And what you can see is that these people are broken in body, mind, and spirit. And it's all talking back and forth. And we treat the body over and over, but they keep coming back. We treat them over and over, and we start thinking about their mental state, and maybe don't come back quite so often. And occasionally, we realize that they need to be connected to something greater than themselves, and these people actually may start to move forward out from underneath those bridges. If they don't, oftentimes they pass. And that's just the way that things work. So with your patients, the mind, body, and spirit is the connection that allows this inherent healing potential to be optimized. So when you look at your patient, you want to say, how healthy are they? Because oftentimes our treatments are actually more invasive, and they're actually trauma to the body. A great example of this is surgery. Surgery is a incredibly traumatic event on many levels. And we tend to think of it now sort of almost routine. It's very dangerous because people still die from surgery. One of the best doctors I ever knew who understood this principle was an MD by the name of Dr. Block. I hope he's listening, but Dr. Block we used to be in Kern County. And he was there for years. He was a chief surgeon. He was an amazing, amazing surgeon. But I sat there and watched him, and he would come in and look at his patient. If it was an elective surgeon, he would spend a lot of time thinking about this patient, looking at the labs, doing his physical diagnosis, talking to the patient, asking the questions, where's your family? Making an assessment of the vitality, because he knew his surgery was going to be traumatic. And there were times he said, this patient is not ready for my surgery yet. Where's his family? We need to get him here. It's important to this person. What is his nutritional status? Not so good. We need to bolster that. And he would facilitate this so that when they did the intervention, the outcomes were better. People got well. I mean, it's a little known secret that physicians really don't heal people. What we do is we are really well-educated facilitators of health. But in the end, we always have to wait for you, the patient, to heal. The place where you really see that is in the intensive care unit. This is where people are literally laying on the knife of whether they're going to live or die. And so in medicine, we support all of the structures that we can think of, all of the systems we can think of, the respiratory, the cardiovascular, right, the nutritional system, the renal system, all of those systems, we support them. If they have an infection, we give them an antibiotic or multiple antibiotics. But there's no antibiotic that will sterilize a patient. All we do is we buy them time for this to finally kick in and take over. And those are the ones that go to the floor and eventually walk out, or the ones that go to the basement, unfortunately. So this is an incredibly important aspect of medicine for us to consider. One of the principles we talk about, first day, first week. And then this has to do a little bit more with how you're wired. Structure, function are reciprocally interrelated. Now we understand this. For instance, if I was to say to you that this person comes in and they are having a heart attack, okay? Or cardiac ischemia is one of the ways they talk about it. For you, what would you think would be the symptoms that this patient might be complaining of? What do you think? What do you think? Chest pain. That's a very common one. What other symptoms? Shortness of breath, right. Any other? What about you? Numbness. Where? In our arms. Any specific arm? Left. It likes to have left. It could be pain too. Pain and numbness could be in the arm. Okay. Any other symptoms? What's that? Pedal edema. Not so often, but possible. Okay. How about sweating? Diaphoresis common. Unfortunately, most of those symptoms you named are what men usually come with. Women can be coming in and be completely quiet. You know, I just don't feel very well. I'm a little fatigued. You know, you do EKG on them and they're infarcting their face off, right? So you have to understand that there is variability in your patients, a lot of variability. But anyway, let's get back to this example. So let's say we have the common presentation, and let's just look at the arm pain. Why does a patient have arm pain if they're having a heart attack? It's called referred pain. That's exactly what it's called. But why is that happening? Who said that? What did you say? Everything is connected. Awesome. Everything is connected, right? That's what they say in neurology too, by the way. You know, you study all the pathways and you spend about 6 months cramming your head full, and then he goes, of course it's all just all connected too. And you're like, oh, thanks. You could have said that in the beginning and we've been all good. All right? But at any rate, so yes, but how is it connected? So I'll give you a hint here. All right? So let's imagine, heart attacks are kind of like an old John Wayne movie bar fight. Okay? Think about an old John. Anybody not seen a John Wayne movie bar fight? Okay, well, I know what you need to do today, okay? All right, so you need to go find some good ones, all right? Anyway, what happens is that usually you got these cowpokes who've been out on the range too long, okay? And they come in to town and they get paid, mistake, okay? And they go into a saloon. And they go in the saloon and the saloon's busy and they go on there and they elbow people away from the bar and say, I need a drink, right? That's usually how it starts, okay? Right? They're an irritant, right? So in a heart attack, what happens is for some reason, there's lots of reasons, we won't go into them, but for some reason, there's no blood reaching the heart. So the cells of the heart are going, hey, this is not good. I need oxygen and other nutrients. Help, help, an irritant. The cells are now having issues. They're becoming ischemic. So back to the bar. So they're irritating other people. So now the guy to the right and the left are kind of mad at these other guys, and pretty soon there's an argument ensues, and somebody throws a punch. But the guy ducks, and he hits the other guy. And before you know it, the whole bar is fighting. You know, even people being thrown off balconies, and it's impressive always, right? So what happens in the heart attack is that with this ischemic, the irritant gets bigger and bigger, and it starts to feed this signal of saying, I am irritated, and it starts to spread, and it goes to these nerves, sympathetic nerves, that go back to the spinal cord at the levels between T1 and T4. And it goes in there, and it goes into the backside in the sensory area, and there's these interneuron pools, which is the other people in the bar, and it gets them all excited. Now you have a full bar fight going on in the spine. And inevitably, someone gets thrown out the front window of the saloon bar, right, into the street. And now the fight's in the street, and it's messing with the whole town. So what happens in the spinal cord is that this irritated pool, interneuron pool, irritates up maybe 1 or 2 levels, possibly 3, and goes to the other side, and it ends up having signals coming out the front of the nerve of the spinal cord to the organs that are innervated. The respiratory system gets irritated, shortness of breath, right? It irritates the nerves that say that you have pain. There's nothing going on in your arm, but in the nerve pool is the nerves that have pain, and they start to register in your head. You have nerve pain, a numbness. That's referred pain. That's structure and function relationship. The function of the heart has altered the structure. And you begin to have sympathetic changes in the different organs and in the body. In fact, the skin begins to show a different texture. It feels differently. You can diagnose when there are organs that are in trouble based on what happens with the structure. And that's the diagnostic aspect of osteopathic manipulative medicine. Structure and function are reciprocally interrelated. That make sense? See, you don't have to go see a bar fight now anymore. Okay? And then the fourth principle is rational treatment is based upon understanding the basic principles of body unity, self-regulation, and the interrelation of structure. So every time you see a patient, no matter what kind of patient visit, you walk in and you say, how connected is this person? How is what's going on with this person today related to other aspects of themselves, other aspects of their possible mental and spiritual aspects? It may be that depending on how sick they are, you don't have time for these other ones. So yeah, let's go for it. You know, if you get into a nasty car accident anywhere in the world, I want to be here. Right? We do the best with acute medicine at any other place. You will probably walk out if you were reasonably healthy going in. Okay? But maybe not. Maybe after we do this stuff, we're still waiting for this health to take over and it's not catching on. They're not getting better. Why is my patient not getting better? Happens all the time. Why is this patient continually getting these infections? You may have to go into these other areas. So you consider the interconnectivity. Then you start thinking, how healthy is my patient? How vital are they? Are they strong enough to withstand what I'm going to do to them? If it's cancer, chemotherapy, do you all know what chemotherapy is? Yes? Do you know what it really does most of the time? It's about making your patient so sick that the cancer cells begin to die, and they hope you survive and over the top of it and walk away. They're basically putting you that sick and that the cancer cells, the fast-growing cells, die first, and then they pull you out of it. That takes a lot of vitality. For those of you who have patients or family members who had cancer and seen it, you know what I'm talking about. Okay? And then structure function. How is the structure related to that? So Andrew Taylor Steele walked around and worked with patients who had structural problems, who had falls, and you know, in those days, I mean, you were kicked by a horse, you fell off a wagon, I mean, all that kind of stuff is going on. You know, there are crazy stories where people documented where there was this farm guy, he was a rancher, one of the hired hands, he'd fallen off his horse and he was paralyzed. He was laying there, he was paralyzed. He was still alive, but he was paralyzed. He couldn't move his hands and feet. And so they asked for Dr. Still to come see him, and Still looked at him and he saw that there was a disarrangement, or the cervical spine, there was something about the movement, and it looked funny. His head was cocked to a weird angle. In those days, they probably let this guy die, because what else are you going to do for him? And so Dr. Still looks at the guy and says, he goes, you know, just blink your eyes if this is all good, but I could probably help you or I might kill you. I can't tell which. Right? Those days, that's what it was like. And he says, would you like me to try? And the guy blinked that he did, right? So literally the description is he put his feet, the guy's laying down, Still got down there, put his feet on his shoulders, and grabbed a hold of the guy's hair and pulled on his head. And the dislocation, there was a dislocation of the spinal cord up at the top of probably somewhere at C1, C2. It clunked and went in, and the guy could move again. Right? That's crazy. We would never do that today. Right? But that's the kind of things that you know, impressed him, that there was a structure-function relationship in a big way. Right? So anyway, rational treatment, what you decide to do for your patient, whether that's going to be pharmaceutical, whether that's going to be surgical, whether that's going to be manipulative medicine, whatever it's going to be, you take those other three into considerations, and that's how you see your patient. So people say osteopathy is more holistic, right? Well, this is the holism. This is what we're talking about. And you know, you were asking me about what to prepare for if you want to apply for Touro University, California. And I said that you should probably think about knowing what you're getting into, right? Knowing what osteopathy is about. And if I swear, if I hear another student say to me, it's more holistic, I'll just like pull my hair out. I go, no! It's more than that. You have to understand it. A Ferrari is more than just a really pretty car, right? So I gave the example earlier that going into osteopathy, if you're going to do it, if you want to be an osteopathic physician, I suggest that you research it. Spend time, find docs, shadow them, talk to them, ask them why they got into it. Ask them what it means to them. Ask their patients why they come see them. Learn how to drive that Ferrari a little bit before you lay down that $200,000 for the car. Because unfortunately, that's what medical school costs these days in most places. It's kind of expensive. It's kind of like buying a house that you don't live in, right? But you carry it in your head all the time. They can't take it away from you, right? So it's something to think about. All right, any questions that I can answer about osteopathic medicine? None? Really? Yes, ma'am.
What exactly do they teach when they go into the spiritual aspect?
Great question. What do you teach when you go into the spirit aspect of health? Well, see, this is a place where you have to think about the uniqueness of your patient, just like you have to think about the uniqueness of your patient in their body aspects. Because no two of us, as much as a lot of people like to think that we're very similar or the same, we're not, right? The uniqueness of each individual is really important when you start to think about the health of that individual. So the spirit aspect, you know, you don't have to be someone who's spiritually enlightened. Most of what I teach, which I intend to teach this, and we teach this in the doctrine courses, is that we have to understand that people need to be connected to something greater than themselves. Okay? A person who is only of and within their own self and their own place is a very lonely, disconnected place. And we are social community animals. There's a reason why we get together. There's a reason why through all of culture, of human culture, we have gotten together in communities. There's also a reason why almost every civilized community that ever had been studied, there was some sort of spiritual connection and practice. There's a reason why that is, okay? So recognizing that your patient has something is probably paramount. And then if they don't, finding a very politically correct, we'll just say, way of suggesting that they might look for some way of finding a place. And do not steer them in any particular way. It's not your job to be the preacher as a physician. It's not your job to be a doctor, a police officer or a judge or a parent. You're a physician. It's a different thing. So you try to steer them in areas that would lead them to that. In some cases, you know, you make suggestions about where they might find it. Find out what's important to them. Again, if they say, you know, what did you used to do that make you feel like you know who you are? I used to climb on top of mountains and just sit up there for a week. When was the last time you did that? Oh, it's been 10 years. Like, well, maybe you're overdue, right? Maybe you're overdue. That kind of stuff. Does that answer your question? Sure. Any other questions about us? Yes, sir.
Two questions. What is your specialty, and what made you want to become an osteopath?
Well, I'll answer the second one first, okay? I was an engineer. I did broadcasting. So I kind of sat back where he is, okay? And I used to design and build studios. And I did network stuff, so I did a lot of satellite work, okay, at the time. And I got to the place to where I was either going to put on a suit or do something else. And I didn't really feel like putting a suit on. As it was, I was a field engineer at those times, so I was traveling around a lot. And I had met two of my friends, my close friends, had gone into osteopathic medical school, one at Kirksville and one at Pomona. And I kind of took it as my job as being a good friend to keep their sanity, especially in the first couple of years. So I made sure that they got away from their books often enough that they were healthy in their mind, let's just say, all right? I was a bad influence, all right? And anyway, I learned quite a bit about osteopathic medicine, and it made a lot of sense to me. Because it was more like looking for for more deeper root causes why someone doesn't get better. Just like when I was an engineer, if I was listening to a pair of speakers and I heard maybe a buzz or a click or something, I wouldn't just immediately replace the speakers. I start tracking back the signal. And if this was something we had done that jumped on the bird, it may be at a mic that's in New York before we finally find it. But in osteopathy, we kind of strive towards working that way and facilitating that part. And that made a lot of sense to me. And so when it came time, I said, all right, I'm gonna take the leap. So I sold everything I had and went back to school and studied chemistry and got a chemistry degree. And then I went and applied to medicine. And I only applied to osteopathic medical schools because I had worked in hospitals when I was a very young man, and I didn't really find that I got along with a lot of the MDs. Now, since then, I've met some really great ones. But at that time, that's kind of how it was. So amazing enough, I got in. Amazing enough, they kept passing me. And one day, I was in a hospital, and somebody tapped me on the shoulder and said, "Doctor, what are we going to do with this patient?" And I was looking around for the doctor and realized it was me, right? So that's what happens, okay? One of the things that happened during medical school, though, I had a lot of trauma when I was a young man. I fractured my skull. I had concussed myself many times. I was rough on my body when I was a young man. And I was compensating a lot, and I didn't even know it because I just kept going, right? And I had somebody treat me osteopathically using their hands, and I remember the day. And I sat up off the table, and I was looking out of the eyes of a different body. I had forgot what it felt like to be fully functional. It was huge for me, huge. And so for me, that really impressed me. Up to that moment, I was just thinking, yeah, manipulative, that's another skill I have in my back pocket. I can use it, that's cool, right? But then I realized that it had a lot of potency, a lot more than I had thought about. And I also realized I had some skills for it. I was pretty good with my hands, and I transferred really quick. And so I kept pursuing that. So I'm board certified in neuromuscular medicine and OMM. So I specialize. So I see patients. Really, my patient pool is very funny. This is what happens when patients come to you, right? All right. So this should look familiar. These are all patients. Right? Typical treatment, right? What you do is you look for the most density. You lay your Gaussian curve on that density. This should sound familiar to some of you, okay? And then you draw a mean. And then you do 2 standard deviations on either side to get your confidence interval. Yes? Okay? And then this is what you do for the people who present in this way. Statistically, these other people who fall out are called outliers. And you can say they're outliers. Statistically, I don't have to really think about these people because they don't fall within the curve. Unfortunately, this guy is your mom. Or this woman is your mom, right? Okay? Oh, it could be. Never mind. Okay. So this woman is your mom. So she falls out. And what I found is that these are my patients. The people who do not respond, they get sent to me. So I see all kinds of crazy stuff. That they have been everywhere. People say that people who use their hands like I do are physicians of last resort. So, does that answer your question? Yeah. Any other questions? Yeah.
For Touro, how many hours are done for the
First 2 years, about 300 hours. Yeah. And then the 3rd and 4th year, much less, but that's changing because I'm the chair now and I'm changing that. Yes. Yes?
What about doing research after you get your DO and then you want to go into academic research?
You could? Absolutely. Absolutely. If you wanted to be a researcher, absolutely. But
Yeah, like a clinical investigator.
yeah. The thing I'll tell you is that the target for Touro, California, okay, is a family practice doc that uses his hands or her hands very well. That's the target. Now, that doesn't mean that you can't be other things, but the curriculum is around forming a primary care doctor who's pretty good with their hands, okay? But like I say, you can become a pathologist, you can become a researcher, you can do whatever you want if that's what you want. Yeah. Yeah, any other questions? Am I running out of time here? What's it? Yeah.
What are your thoughts about DOs and like emergency medicine and hospital medicine? Just anything.
They're all over the place, and they actually do pretty well in the ER because they have another quick tool in their pocket. Sometimes a little manipulation can go a long ways to helping somebody who comes in with just a minor musculoskeletal problem, as opposed to sending them away with just drugs. So as far as working in the ED, asked how does DOs work in the emergency department, and yeah, they're great ER docs. I know several that are good friends of mine. But emergency medicine is a really fun place to work, but it's intense. There are very few gray-haired docs that work in the emergency medicine area. Okay. Any other questions? Yeah. Am I about done? Yeah. All right. Well, thanks for coming, you guys. Good luck today. Have fun.